All right,
Okay.
starting the timer, and here is the question.
Mhm.
Yes, so if you have read and understood, kindly begin your history. Take it.
Okay. Hello, I am Mohammed Al Ayan, one of the exam candidate. May I confirm your name and age, please?
Your age is 67, you can tell any name. Tina, 67.
Hello.
Oh, am I supposed to answer that?
Yes, yes.
Oh, sorry. So my name is Aiza. I'm a 67-year-old.
Yes.
Nice to meet you, Mrs. Aiza. Today, I have been asked to ask you a few questions regarding your condition. Are you okay?
Yes, I'm fine.
Okay. How can I help you today?
Well, I came here with complaint of I fell down and I had vigorous shaking.
Mm-hmm.
So
I am sorry to hear that. Can you talk me through what's the happen exactly?
well, I was doing my household work when I suddenly felt lightheadedness and I fell down and I had an episode of seizure. And I don't remember the whole event, but people around me told me that I also passed urine in my clothes. And then after some time, I regained my consciousness.
What were you doing at the time?
I was at my home in kitchen.
Did did any witness the episode?
Yes, I was with my sister. She witnessed the
How did you
episode.
describe the episode?
Well, I don't exactly remember what happened, but she told me that I fell down and then I started shaking, and the episode was there for about 5 minutes.
When did you first experience your first seizure?
This is the first time I experienced the seizures.
How did you feel immediately before the episode?
I had I felt some kind of smell right before the seizures. Yeah.
Did you hit your head?
No, I don't recall hitting my head anywhere.
Did the whole body shake or only part of the body?
I don't remember myself, but my sister told me that my whole body was shaking.
Did you bite your tongue?
She was very quick to respond, and she turned my body to the left side, so she didn't say there was any history. I didn't feel any pain afterwards either.
Did you wet or soil yourself?
Yes, my sister, and after I woke up, I remember that I had passed urine in my clothing.
Have you noted head or eye deviation toward the one side, or excessive eye blinking, or limb smacking?
All I remember that before the episode, I felt some kind of smell. Other than that, there was nothing.
Were you confused or drowsy or ashing muscles or unable to speak?
I was unconscious during the episode.
Did it occur in morning time or at the night time?
It was it was noon, afternoon.
Has something like this ever happened before?
No, this is the first time I experienced something like that.
Okay. Have you noted any fitness occur event like sleep disturbance?
Yes, I've had some sleep disturbance in the last week.
How frequently do you experience your fits?
This is the first time I experienced 2 episodes. Sorry, this is the second time.
Have been investigation before for any central nervous infection or head injury or?
No, there's no history.
Have you? Okay. Have you had any arm or leg weakness?
Time over?
No. So,
okay, sorry.
Any arm or leg weakness? No.
No, I don't have any weakness in my body. I did feel tired after the episode.
Did you throw up?
No, I did not throw up.
How's your appetite?
It's fine. There's no problem.
Do you have any other medical condition?
Yes, I am diabetic and I also have blood pressure.
Do you have any surgery before?
No, I don't have any surgery. History of any surgery.
Medication?
Yes, I
Do you
take
take any
medication
medication?
for. Yes, I take my medication for blood pressure and diabetes.
What is the dose?
I take metformin for diabetes and ACE inhibitor for blood pressure.
Do you have any allergy against these drugs?
No, I don't.
What's your occupation?
I'm a teacher. I used to be a teacher. I'm retired now.
Who is at the home with you?
Yes? Sorry, I can hear you.
Who is at the home with you?
My sister was at home with me. Yeah.
Do you smoke?
No, I don't.
Do you drink alcohol?
No.
Anyone in the family have the same problem?
Yes, my uncle had seizures.
I am sorry to hear that. What do you think the cause?
I'm not sure. I only remember like he had the episode once in front of me. So I don't really know the details of his.
What are you most concerning about?
Well, this is the second time I had this episode, and I'm very concerned why I started to have this kind of problem.
What are you hoping us to do for you?
I would like to know the cause of my problem.
Do you have any chest pain, short of breathlessness, any muscle or joint pain?
Yes, sometimes I have joint pains.
Anything else you want to add?
No, that's it. Thank you.
Thank you. Nice to meet you, Mrs. Aiza.
Thank
Can
you.
you summarize your history taking now?
summarize Mrs. Isa, 67 years old lady brought to the emergency department with complaint of the episode of fall down with vigorous checking. This made pus in urine in clots at the time of event. The patient regained consciousness after some time and do not remember anything. And the patient, she has now case of the control type 2 diabetes mellitus and hypertension. My professional diagnosis could be SEIZURE, could be another differential diagnosis, could be brain tumor, meningitis, encephalitis, and electrolyte disturbance.
Very good. How would you manage this patient? What investigation?
Okay. After history and examination and investigation, follow blood count and electrolyte and blood glucose and calcium and magnesium and anion gap and lactate and prolactin, and can be done ABG and CT scan head with history regarding the case history of the trauma, and can be done EEG and MRI.
And how should this patient be treated? What should be the treatment?
The treatment stabilize the patient after ABC approach, move the patient to the safe place, start after airway and breathing and circulation assessment, start anticonvulsant therapy, after discuss with my consult phenytoin 1 gram loading dose, then 300 milligram once daily, and 4 milligram dexamethasone to decrease brain edema. After that, discuss neuro-oncology with MTD meeting, and could be start guide biopsy and resection and debulking in case of the brain tumor.
Good, thank you. You, on average, you have taken 3 minutes extra. Otherwise, like, you have covered everything, and you have managed to cover everything, but you took little extra time.
Okay, ma'am.
Thank you. Yes. Anyone
Thank
else
you.
want to give? Thank you, Dr. Isa. Thank you, Dr. Mohammed. Anyone else want to give feedback? See, you have done it today, so you have tasted it, how easy it is. Even if you'll be on the other side, on Dr. Mohammed's side, and you'll be asking questions, so that's how easy history taking is. No matter
Right.
what station is, that's how you do it. But on average, he took little extra because it's, yes, but they are happy since you covered everything. But my concern is to keep them within given time. So otherwise, Dr. Mohammed's history taking is good.
Okay, ma'am.
Hi.
Yeah. Hello, yes.
Yeah, it was very nice history taking.
Yes.
There is just one simple way to save the time.
Yes.
If we go in a particular order,
Yes.
we will not repeat our questions. For example, if the patient is presenting with SEIZURE, we could divide our questions in 3 parts: before the event, during
Yes.
the event,
Yes.
after the event.
Yes.
In this manner, we will not repeat questions, number 1. Number 2, it's important to pay attention to what patient is saying. For example, if he has asked one time that, has this happened before, and she said no
Yeah,
or
yeah,
yes,
yeah. Mm.
it is very important not to repeat that question. Otherwise, patient may say, "Doctor, I have told you before, were you not listening?" And number 3, when we ask some personal questions to the patient, it is very important to
Take consent, yes.
to take a consent or give a polite warning kind of thing.
Yes.
Especially when asking about smoking and alcohol. It is not appropriate to directly throw the question and without any warning that, do you smoke or do you break alcohol? Some patient might get offended.
Yes.
That's all. That's all. On the
Yes.
whole, it was very
And
comprehensive.
fourth or fifth, I could say, to connect with the patient, like connection is also more important. But sometimes I understand, because not everyone have a very vast vocabulary. They have limitations. So I know they're struggling. They're in the pathway of improving. So that's why they take longer time on, and they have lack of connection and all that. So it's many factorial. Yes. Thank you. Yes, anyone else want to add anything? Or should we move on? Dr. Vishek, are you ready? You said second.
Yes, please. Yeah.
Yes. So if you're ready, I'm starting the timer.
Yes, please, ma'am.
All right. Here is the question.
Ma'am, just a question, like I'll consider it as a patient or I just discuss
No,
it? Ma'am?
like they're doing it now. Without like how you will be doing it, you have to talk like that.
Ma'am,
Not
what I
no,
have heard, ma'am, just a second,
yes,
I'm just
yes.
saying, what I heard recently, ma'am, Dr.
We have
Sunday
Dr.
actually
Sunday
told
here.
us, yeah, he told us that whenever we are doing the examination, the examiner sometimes say, assume that I am patient or something like that. Whenever I explain the points, the
Yes.
examiner just say the findings after certain point, like after inspection, he's just saying the finding. After palpation, after he's just saying the finding. So how can I do it, ma'am? What do you suggest actually, ma'am?
Like you're telling me, because you
Okay,
know
okay.
if it's shoulder examination and if it's 23 years old athlete and
Yeah.
patient has only come for health control, so how
Yeah.
would you expect
Okay.
this patient's shoulder joint to be? So just tell the findings how you would expect it to be, but
Okay, ma'am.
there'll be no patient. So even if examiner asks you for the findings, so you should be knowing it yourself.
Okay, ma'am. Okay.
Yes, considering the scenario, patient is fit, just
Okay.
there for
Okay,
regular,
ma'am.
yes, health control.
Okay.
So I'm starting.
Should I begin, ma'am?
Yes,
Yeah.
begin please.
Okay. At first, I'll enter the examination hall. I'll wash my hand and don a PPE if it is required. After that, I'll check patient's identity. I'll tell that I'm Dr. Vishek, one of the surgical candidates here today. Then I'll check patient's identity by asking his name and age. And after that,
You'll take the
after that,
consent.
I'll take
Yes.
permission from the
Yes.
permission from the patient that today I am going to do some examination on your shoulder.
Yes.
So that involves looking at your shoulder, doing some movements, and doing some spatial tests. If the
Yes.
patient would allow me to do that. And after that, I'll ask the patient to sit on a chair, and I'll ask the patient to lower his get rid of his shirt and the shorts below the shirt, and I'll ask the patient if there is any problem over there or not.
Okay.
Okay, and I'll ask before the examination that if there is any pain or not in his shoulder. I'll ask if he has any pain over any shoulder or not. Then I'll start by examining one shoulder, then another shoulder.
Yes.
So at first, I'll take a closer look to both shoulders, right? The right shoulder from the front, from the sides, right and left side. And then I'll ask the patient, I will examine from the back. I'll just check the shoulder contour from the back. After inspection, I'll do the palpation, and before palpation, I'll confirm that if there is any pain or not. After that, I'll check the temperature and tenderness. I'll check the temperature from the clavicular area, shoulder area, and the back over the scapula, and if there is on both sides. And after that, I'll check the tenderness starting from the sternoclavicular end over the clavicle, acromioclavicular joint over the cricoid process, over the head of the humerus, over the greater trochanter, over the spine of the scapula, and also over the borders of the scapula or not. And by checking on the I'll check after that on the other side also. And after that, I'll check if there is after checking the temperature, tenderness, I look for the pulse of the brachial pulse in the hand. If there is any alteration or not, I'll also check the carotid pulse. And after that, I'll ask the patient to move the joint. At first, I'll ask the patient to fully extend the hand forwards as far as he can to check for flexion, and then I'll ask the patient to move the hands towards the back as far as he can. Then I'll ask the patient to place his hand behind his head and put some pressure over the elbow backwards. And after that, I'll ask the patient also to put both hands behind the back, and also put some pressure backwards, and ask the patient if he feels any pain or not during doing that movement. And after that, I'll ask the patient to abduct the arm, and then I'll ask the patient to adduct the arm. And after that, I'll ask the patient to flex his elbow joint 90 degrees and do inwards and outwards movement to check for internal and external rotation. Then I will check the movement by telling the patient if he feels any kind of pain or any discomfort, he will just
How
let me
would
know
you
it.
instruct the patient to adduct the arms?
Okay, ma'am, I will instruct the patient. Please do can you please do that what I am doing? Can you just please follow me?
Okay.
Okay, and after that, I will also do the abduction and adduction movement. And after this, I'll just move the joint by placing a hand from the behind actually, by placing my one hand over the shoulder joint, and then I'll move it. During doing all the movements, I'll look for if there is any cubitus over the joint or not. Then I'll do some special test that includes, at first I'll do the painful arc test, that if there is any pain over in the arc or not. I'll put patient's hand over his head, full abduction. Then I'll ask the patient to neutralize his hand to the neutral position. If there is any pain over there, I'll ask the patient. And after that, I'll do the empty can test. I'll ask the patient to abduct the hand without bending the elbow at 90 degrees and slightly forwards and thumb towards the ground. And I'll ask the patient to press against my hand. If there is any pain over there, I'll check for that. After that, I'll do the hornblower sign. I'll ask the patient to bend the elbow 90 degrees and also abduct the arm 90 degrees and ask the patient as far he can do the external rotation. I'll check if there is any pain over there or the patient can't maintain the position or not. These two things I'll check. After that, I'll do the external rotation against resistance. I'll ask the patient to bend the elbow at 90 degrees and the shoulder slightly abduction and give some resistance against my hand in the external rotation with the external rotation force. I'll check if the patient is having any pain or not. After that, I'll do the internal rotation against resistance. I'll ask the patient to take one of the hand behind the back, and I'll ask the patient to put some pressure with the patient's palm towards my hand. If there is any pain over there or not, I will just take that. After that, I'll ask the patient that I will just take some sensation over the shoulder area, and with the cotton tip and the neuro tip. I'll just first check in the front of the chest, then I'll check the badge area of the hand over the distribution of the axillary nerve. And after that, I will also check the action of the axillary nerve, like doing the abduction at 15 to 90 degree level against resistance. And then I'll ask the patient to put the hands on the wall and give some pressure over there. I also look if there is any winging of the scapula or not. And after that, I will ask the patient to dress up. I will ask the patient if he needs any help or not, and I'll thank the patient. I'll wash my hand.
Good. So
okay.
What were your, if you can summarize your examination, please?
Okay, yes, ma'am. To complete my examination, I'd like to check the cervical spines or thoracic spines, and also I'd like to check the ankle joint elbow joint examination. And today I have examined
incomplete neurovascular examination of the upper limb.
Yes. Yes, ma'am, complete neurovascular. And today I have examined a 20 years old athlete who came here for a regular health control checkup. And on inspection, there was no visible scar swelling, tenderness, scar swelling, skin changes, changes in the hair distribution, or any visible or engorged vein over there around the distribution, around the region of the shoulder joint. On palpation, there was bilaterally normal or equal temperature, and no regional tenderness over there. And by doing the active and passive movements, there was no limited range of motion. There was no painful range of motion of the movement, and there was no crepitus that was felt over the shoulder joint. And doing some special tests, there was no There is
what
no
was your
pathology
yes, what was your provisional diagnosis?
So according to the scenario, my provisional diagnosis is the condition of the shoulder joint of the both side is normal, within normal
Good.
limits.
Good.
Yes, ma'am.
If there was a possibility that patient was unable to extend if there was unable to abduct the arm, then what would have been your diagnosis?
Yes, ma'am. There may be presence of the painful arc syndrome, like between the 60 to 120 degree, or
Yes.
there may be positive MT-CAN test, which may indicate the supraspinatus impingement or painful arc syndrome, ma'am.
What would have been the management of the patient in that
Okay,
scenario?
at first I'd like to go for a baseline investigation like full blood count, CRP level, to check if there is any evidence of infection over there or not. And after that, I'd like to do the shoulder X-ray, shoulder X-ray, anterior, posterior, and lateral view, and to become more confirm about the diagnosis, we can do the oblique coronary MR arthrogram of the shoulder joint.
Good.
And after that, if there is patient have the subacromial impingement, as the patient is younger, we would go for, at first we would go for some conservative treatment, like giving some painkillers, doing some physiotherapy. We can refer the patient to the physiotherapist and also give some muscle relaxant. And if it is not resolved by that, we can give intra-articular steroid injection. And after that, if it is not resolved by that, we can go for surgical management. We can go for arthroscopy and subacromial shaving of the joint.
Very good. Excellent. Yes.
Ma'am.
Anyone else want to give feedback?
Ma'am, during the examination, I didn't interpret like which test is for which muscle. If anyone wants to know, I can explain that, because it would kill time.
Yes, if anyone wants to, you can share it with them. They are, I think, happy. Yes, they're all happy.
Thank you.
Good. But then where I felt confusion, I asked you. So that's how they will do in examination as well. I don't think it will be other way. Like if they think that, okay, or if they feel that they didn't understand how you're explaining, then they can ask you, okay, now patient has crepitus or something. So what would you do next or something like this? But they'll be, my scenario was very brief, but definitely in examination, they'll give you enough. There are only two common scenarios that come in exam when it comes to shoulder examination. So
one is, ma'am, the subacromial impingement, another is rotator cuff tear, right?
Yes. Subacromial impingement and rotator cuff tear. And in rotator cuff tear, patient will be old. Yes, I think so.
Yes, ma'am.
Yes, and they'll
and for
be
old
actor.
patient, mostly we will go for conservative management first. I think it depends on the age.
Yes, and patient will be actor, like in whatever case is. So there'll be no finding, but still they'll give you enough description in the stem that you will not get confused. You will know it for sure.
Okay, ma'am. Thank you.
Yes, good. Thank you so much. But then from tomorrow, I should maybe pay more attention to the recalls of October, and then I should focus mostly on them. All right.
This shoulder came this time. Yes, ma'am. Thank you.
Shoulder came this time?
Yeah.
Okay.
Yeah.
Because what I understand, shoulder and hand examination, it's common.
Ma'am, the fact is shoulder examination are not so common before this October exam, but in October exam, the shoulder examination came. So that's why this is important, I guess.
Well, I think in Dublin or somewhere it came before.
Yeah.
How are you, Dr. Sunday? Nice to have you.
Hi. Shoulder examination, it came, and they both, I think they both scenario.
Yes.
I think from what I understand, the examiner, maybe they interchange the scenario from candidate to candidate.
Okay.
They're just simulating, I told you.
So which means there is no, it depends on the candidate. and
Yes.
what the examiner is trying to stimulate for you.
Okay.
I think for Ireland, it was a rotator cuff tear.
Yes.
I think
Okay.
for Sheffield, it was a supracumeal impingement.
Okay.
So, and like I told Dr. Abhishek before, what he was trying to explain, in the exam or in the station, the man already said, okay, when I said on the visual examination, I would like to see, he said, okay, there's obvious atrophy of a supraspinous muscle. Okay. So then, okay, on palpation, is there anything? He said there's no pain on palpation of everything. So he keeps saying, when I said, okay, I would like to do passive movement. So I was demonstrating with my hand. He kept saying, okay, on the abduction, there's pain. On the flexion, there's no pain. Next, okay. Then I said, okay, now I would like to move actively. Okay, then each movement I say, he keep telling me, oh, there's pain, there's no pain. So when I tried to do, I did a raise hand and I let it drop passively. So he said there's pain between 60 to 90 degrees.
Yes.
Then, okay, and I said I want to do anti-cramp test. He said it's very painful. So then I told him about putting the hand at the back and tried to do a gaze restriction. He said, yeah, not so painful. So that was how we walked through the whole scenario. And at the end, so when you are saying what you want to do, you keep telling you what you are meant to, the symptoms or the sign. And from there, it was obvious the diagnosis, and in diagnosis, you follow the normal management, surgery. But one thing he said is for surgery, he said, what simple procedure, like not big surgeries, like tendon release. You know, so that's another thing maybe that is not in the traditional way. But the rest, yeah, just follow the sequence.
Yes.
And also for the cranial nerve station, the examiner was simulating the patient. So it was like, okay, consider me to be the patient, proceed. So I said, okay, I would like to start with the chart. He said, okay. I said, are you wearing glasses? He said, no, it's not using glasses. Okay, I said, can you look? So I started asking, okay. He said, you can only see from the third line up to the third line. You know, okay. Then during the eye movement, you know, I was using my hand and the examiner simulated the nystagmus on lateral gaze. So something like that. So it depends on the examiner and this thing, but you are going to continue as you progress. Like it's like you are acting with the examiner, or the examiner will be telling you what to see in each, whether it's inspection, whether it's palpation, whether it's percussion, whether it's auscultation. They will tell you everything. For example, pulmonary embolism during auscultation was like, okay, this is there's no vesicular sound. The vesicular is going to tell you what to hear, and you move to the next one like that.
Yes. Yes. Is it clear to everyone what Dr. Sanjay is telling you? Yes. Yes, I think so. They're listening very quietly and obediently. All right. Anyone have a question, or should we move on? Can I have Dr. Mohammed Al-Tahir? And then I can have Dr. Ishfaq and Dr. Ulfat. Or maybe if Dr. Ishfaq said he will go third, so maybe they want to go. Yeah. Dr. Mohammed Al-Tahir, you and I have the same time, right? You have 8:20, 21?
Yes, it's
9:21, okay. All right.
Yes.
So is that okay? They can go first and then you can go.
Yes, I can wait, no problem.
Thank you. Dr. Ishfaq and Dr. Ulfat, both of you, if you are ready. Can I start the timer?
Yes, ma'am.
Okay, starting the timer. And here is the question. Right, so if you have read and understood, kindly begin your station.
Yes. Hello.
Hello,
Good morning, sir.
good morning.
I'm Dr. Ishfaq. I'm one of the doctors working for under Mr. David. I need to call to speak to the cardiovascular consultant about a patient who we suspect have the acute limb ischemia. Can I check that I'm speaking to Mr. David?
Yes, I'm Mr. David. Could you please summarize your case, doctor?
Okay, thank you. Actually, we have a patient, 54-year-old gentle lady who got admitted with us as a case of mild diverticulitis, and we have given her a few intravenous antibiotics and intravenous fluids, and then her symptoms got subsided, and then she acutely had complained of left lower limb severe pain. On examination, we came to know that she's in excruciating pain, and we did few investigations. We did a ECG in this case, which showed the features of atrial fibrillation with broad periventricular complex, and we did an ABG which showed metabolic acidosis with hypokalemia. Followed by that, we did an arterial duplex that confirmed that patient is having acute limb ischemia. So we are concerning about her acute limb ischemia that's posing threat to her limb. Can you please, we would like to have your consultation about this case.
Okay, so is it really urgent? Can you not send it tomorrow morning instead?
Exactly, sir. This is very urgent considering considering the limb is in acute condition, because we are suspecting that the patient is having acute limb ischemia, and it can pose the immediate threat to the limb, and patient may lose the limb because of this acute limb ischemia. So it's definitely urgent, sir.
Okay, do you need to see a cardiologist to review for the preventricular contractions before transfer?
Sir, I think that thing can wait on the moment, and that thing can be done later on once the patient will be shifted to the US center, and then this thing can wait for the moment.
Okay,
Yes,
okay,
sir.
what if, all right. So what do you think of the presumed diagnosis of diverticulitis in light of the patient's abdominal pain? And
Because initially we thought the patient is having mild diverticulitis, and because she was having this pain abdomen, and we give antibiotics and fluids. But considering now the condition of acute limb ischemia, we should have revised. I would like to revise our diagnosis of pain abdomen as a case of mesenteric ischemia, because the clinical features and the investigations are pointing us toward that patient was having mesenteric ischemia.
okay,
Yeah.
how would you scan the abdomen?
I think, sir, that in order to save the time, we should transfer the patient. But if I will get the time during the transfer time, I will definitely arrange a ECG abdomen in this patient, and with contrast, if assuming her renal functions are normal. But if it will delay the transfer, then it's better to transfer the patient first.
You said she has abdominal pain, and you have thought that it could be mesenteric ischemia. What other differential diagnoses would you keep in mind?
Yes, sir. We should keep the possibility of acute diverticulitis, mesenteric ischemia, perforated viscous, pelvic inflammatory disease, any colorectal cancer, any other benign, any other autoimmune disease like ulcerative colitis and Crohn's disease. We should be considering these possibilities as well.
All right. So right now, what is your new diagnosis for this patient?
So one new diagnosis, this patient was having acute mesenteric ischemia because of his pain abdomen, and that the thrombus from the site of the ischemic, wherever it was in his blood circulation, has gone to his leg, and that has completely blocked this circulation to his leg, and that's causing the acute pain in the limb of the patient, and because of the atrial fibrillation, underlying atrial fibrillation. That is the possibility, and that's why it's posing threat to her limb.
Okay. What imaging would you do if it is a mesenteric ischemia?
I would like to do the arterial duplex scan first, followed by that I would like to arrange a CT, CT angiography in this patient.
What if the patient's renal function is not good enough and favorable for a CT?
No, if patient's renal functions are not well, then we have to avoid the contrast in this patient. At the there we can go for the arterial duplex only.
Or magnetic resonance.
Or
We
Magnetic
can go
resonance.
for the magnetic resonance angiography. As in that case, we don't have to give the dye.
Good.
all right. How would you manage this case?
I would like to manage this case before transfer according to the ABCD protocol. Considering it a acute condition, I was starting with the A, B, C, D, and E. I would take some basic blood investigations, repeat few blood investigations like full blood count, repeat the ABG, and repeat the electrolytes and urea electrolytes, KFT as well. Repeat the ECG if needed, and arrange an echocardiogram if needed. But meantime, I will give the patient fluid bolus, antibiotics, and correct his hypokalemia, correct his atrial fibrillation, give the patient anticoagulants, and liaise with the cardiologist if that's possible. But better is to transfer before policing with the cardiologist.
How would you manage the patient's atrial fibrillation?
Atrial fibrillation, we have to give the patient the anticoagulants that we can give with the low molecular weight heparin 5,000 units international units bolus, and followed by the maintenance
Doctor,
dose.
is it low molecular weight heparin?
Sorry?
Do we use low molecular weight heparin in the dose that you mentioned for atrial fibrillation?
Unfractionated heparin.
Yes.
All right, thank you.
Or we can give also the amiodarone cardioversion. That depends upon the severity of the atrial fibrillation. But presently we should keep the patient on the anticoagulants as soon as possible. Yes, sir.
How would you transfer the patient? What kind of ambulance would you use?
We need to have the ambulance which have all the facilities regarding the primary resuscitation of the patient. Have all the facilities for CPR, all the drugs needed in case patient deteriorates, have the intubation facilities, have the anticoagulant, all the facilities, and we should have a anesthetist as well available, intensivist as available, and I would be personally accompanying the patient as well.
Okay. Okay. How would you manage the ischemic limb of the patient?
I will put the patient on the anticoagulants and discuss my case with the concerned department vascular consultant. And there are few possibilities we can do in this patient. Like we can choose the endovascular treatment like Fogarty catheter to remove the embolus by embolectomy. Or if that's not helpful, then we can go for the bypass, like surgical bypass procedures.
Okay. All right.
Yes.
What will you tell her family?
I would like to discuss this case with her family, that your patient is having acute shortage of blood supply to his lower limb, which has deteriorated his condition, and that's why we need to shift this patient to the concerned and the skilled and professional, what we call the vascular surgeon, and that's the reason we need to shift this patient from one hospital to another hospital.
Yes, good.
Okay. All right. Okay, then could you summarize then how would you manage this patient now?
Okay, so I would like to summarize that I have discussed a case of 54-year-old lady who has previously admitted as a case of mild diverticulitis, and then patient has suddenly complained of acute lower limb ischemic pain, and we have done some investigation which has revealed that patient is having acute limb ischemia, and we have changed our previous diagnosis of mild diverticulitis to mesenteric ischemia, and have discussed the case with you, sir, the investigation, the guide investigation we need to do, and finally, sir, you have agreed upon that we can transfer the patient to your center. In the meantime, I will continue the resuscitation and do the needful in case of considering the ischemia, acute limb ischemia in this patient and AF in this patient in consideration.
Okay, all right, then send the patient over, doctor. Thank you.
Thank you very much, sir.
you.
Is there anything, sir, I should do at the moment apart from this?
No, it's all right. You can send
Okay,
the patient
thank you.
over.
Thank you. Thank you very much, sir. Thank you for your time.
Well done, both of you. Excellent. It was kind of a surprise station for Dr. Ishfaq, but think of it, he did very well. He managed to answer every question appropriately. One big mistake, blunder of those that you were telling, that
Yes.
you can revise. Yes, otherwise it was good. Let's hear what Dr. Sunday has to say. Yes, please.
Yes.
Yes, Dr. Sunday.
Yes, you did well.
Yes.
One thing I want to say is that in the station, they won't, under the stem, they won't write anything about atrial flutter, all those things. So ECG will be given.
ECG will be given. Okay.
It will be given. So the step will not contain any of those information. So they will ask, okay, so have you done ECG? Yes. So what does it say? Then you have to read the ECG. Then say the answer. Then
so we have to read the ECG for atrial fibrillation.
Yeah.
And
so
it's
it will be
easy.
given. No. So you have to.
So there will be P waves will be absent in the end.
So because like the case history for the patient will be from the admission day, operative history, and after. And typically, I think post-operative day 3, the nurse on the ward noticed paid leg and called you to come and consult, stuff like that. But this ECG will be given, so you have to read it to the consultant over the phone. You can take it together with you. So, but that is a summary of the ECG, atrial flutter with a blood complex. But it will be given, and ABG will be given also. You have to interpret it also. So it is not. Don't expect it to be part of the step.
Dr. Sunday, there is one thing like in these stations we have preparation minute of 9, the preparation time of 9 minutes. Can we just make notes and summarize? Okay. Sorry.
Okay. Yeah, you can make notes. Of course, you have the pre-station where you can make notes.
Yes, like we can say I have been through the notes and I have been through the ECG and I have came to know that patient was having atrial fibrillation.
Yes.
Of course.
In the preparation time, the preparation minute.
Yeah, if you won't say that, yeah. But if you don't say that, the examiner will still ask you, so have you done any ECG? Yes. So what does it say? This ECG shows that. You know, have you done any ABG? Yes. What does it say? You know, they will still ask you. Then one new question that came out of this station was, do you think the patient has coronavirus?
Okay. Thank you.
Well, of course, the answer is no. For that. No.
Okay. Yes.
Okay. Thank you, Dr. Sunday. Thank you, ma'am.
Thank you.
Thank you, Dr. Ishfaq.
Thank you, ma'am. Thank you, Dr.
Thank you, Dr. Ishfaq and Dr. Ulfat. Thank you, Dr. Sunday and Dr. Abhishek. Let's move on, right? Right. Dr. Mohammed Al-Tahir, please.
Yes.
So if you're ready, can I start the timer?
Yes, I am ready.
Very good. Okay. Here is the question. Right, so if you have read and understood, kindly tell me how many types of diabetes we know about.
There is diabetes type 1, and there is diabetes type 2, and there is gestational diabetes.
Yes.
And also there is one called MODY, maturity onset diabetes in the young, and there can be secondary diabetes due to endocrine pathology,
Okay.
such as acromegaly or Cushing syndrome.
How would you differentiate between type 1 and type 2 diabetes?
Type 1, this is most commonly occurring in children and young people, while
Okay.
type 2 occur in middle-aged patients. It's most likely associated with obesity, type 2,
Okay.
and and also associated with the family history of diabetes.
Okay. Can you tell me, okay, what is type 2 diabetes?
This is due to destruction of the beta cell of islet of in the pancreas, which lead to deficiency of the insulin,
Okay.
lead to hyperglycemia.
Yes.
While type 2 this is due to imbalance between the insulin resistant and insulin secretions.
Can you tell me what is the function of insulin? How does it
Insulin
work?
has
Yes.
increased the rate of transport of glucose inside the cells in the body, and also has metabolic effect for
Yes.
the carbohydrate and the fat and protein. For the carbohydrate, it is the increased glycogen synthesis in the liver, and also it is increased the uptake of glucose by various tissues. For the fat, it is increase the lipolysis and increase lipogenesis, and increase
Okay.
amino acid uptake in the various tissues for the protein, and also
What are other,
increase
yes.
protein synthesis.
Okay, good. What are other hormones which are affected in diabetes other than insulin? Could there be any other hormones?
Glucagon and
Okay.
glucocorticoids such as the cortisol,
Okay.
and also there is somatotropin
Okay.
and catecholamine, epinephrine, and norepinephrine.
How is their role affected?
There is antagonize the insulin.
Okay. Okay. Can you tell me what are the effects of insulin? What are the metabolic effects of insulin?
This is
On carbohydrates and on proteins individually?
the carbohydrate increase the uptake of glucose by various tissue and increase glycogen synthesis in the liver, and also generation of glucose 6-phosphate dehydrogenase from the glucose. And for the fat, it is increase the lipolysis and increase lipogenesis. For the protein, increase amino acid intake by various tissue, and also increase protein synthesis.
This patient requires a surgical procedure. Do you think it matters for the patient that patient is diabetic? How diabetic patients should be managed prior to surgery?
They should be first put the patient in the priority in the operating list.
Yes.
They should have priority, and also overnight admission is not necessary, and also patient might be considering infusion if he is expected to miss more than one meal, and also the starvation time is should be not more than one missed meal, and also patient recommended to take 5% glucose and 0.3 kcal and 0.45 sodium chloride, and also patients should have regular capillary glucose checkup every hour during the operation and after the operation, and also we should check for WHA checklist to identify all the diabetic patients.
All right. Should this checklist be followed for all the diabetic patients or only for those patients who are taking insulin?
For all the diabetic patients.
Okay. All right. Can you tell me what are the immediate and late post-operative complications that patient with diabetes can expect it to have?
Immediate patient might have hyperglycemic
Okay, hypo
or
or hyper.
hypoglycemia.
Yes.
Patient may develop this DKA
Yes.
and also dehydration and electrolyte disturbance.
Yes.
And also there is, for the late, there is infection and sepsis.
Yes. Or impaired wound healing. Who would you
Yes,
involve in the management of a diabetic patient?
the endocrinologist.
Okay, and if you think the patient is diabetic and his or her patient's diabetes is not controlled with oral medications, then what would you do before taking the patient to the theater?
I will shift to insulin therapy, insulin infusion.
Okay, okay. You said late complication could be formation of infection or sepsis. So can you define
Yes,
abscess?
abscess, it is a collection of pus formation due
Yes,
to uh, infection of biogenic organism or secondary infection of necrotic foci.
yes. Can you tell me what are the organisms which cause abscess formation?
Can be bacterial or non-bacterial, bacterial
Good.
such as Staph aureus
Yes.
or streptococci. Non-bacterial can be fungal or parasitic infection or viral.
Can you name one simple test which can detect the cause of abscess?
Gram stain.
Okay. Right. And can you tell me what causes cellulitis? Because diabetic patients are often seen having cellulitis. So what causes cellulitis?
So where is bacterial infection most likely to be caused by group A streptococci?
Yes. How would you differentiate between abscess and cellulitis? Can you name few differences? Yes.
Abscess is most commonly caused by Staph aureus, while
Yes.
cellulitis is caused by group A streptococci.
Yes.
The organisms in abscess will secrete the coagulase enzyme, while in cellulitis they secrete hyaluronidase or fibrinogen.
Yes.
There is extensive necrosis in cellulitis, while
Yes.
there is central necrosis zone in the abscess, and the abscess is localized, while in cellulitis it's diffuse.
Can you tell me why a patient with abscess presents with fever? Bell has gone, but still I want you to answer.
Due to the release of cytokine inflammatory mediation such as tumor necrosis factor and interleukin, which are responsible for secretion of prostaglandin
Yes.
in the perivascular and the vascular cell of the hypothalamus.
Very good. Okay. Can you tell me when would you decide to give antibiotic to the patients having abscess? Diabetic patient with abscess.
If the abscess is not localized or the cavity intend not to lift open.
Would you consider giving to this patient? Patient has perianal abscess, so you'll drain abscess. Patient is diabetic. Would you consider giving antibiotic to this patient?
Yes, after incision and drainage of the abscess.
Okay. Thank you. It was excellent.
Thank you.
Thank you. Yes. Well done. What is CS?
Ma'am,
All
culture
right.
sensitivity.
Yeah, all right. Dr. Mohammed, there are some other type of diabetes as well. Can you tell me?
There's the gestational diabetes
Gestational, other than
and
gestational, yes.
one called Moody. Moody is mandatory onset of diabetes at the young. This occur at younger people than 25 years.
Yes, good. Do we have Dr. Mohammed? Dr. Mohammed Elian? Can you tell, Dr. Mohammed Elian, can you tell what are the other types of diabetes other than Dr. Mohammed Al-Tahir has told us?
Yeah, type 1 and type 2. Type 1 more
Other
common
than
in the
those
pediatrics,
two?
and type 2 more common in the adult.
Diabetes insipidus, there is one.
Yeah,
and
due
there
to
is another.
the first the type 1 due to insulin resistance, and due to insulin resistance, and type 2 due to insulin deficiency. Type 1 could be associated with human glucoside antigen and have HALA, and not associated with the type 2. Could be type 1 associated with other autoimmune disease.
Okay, what other diabetes could be there?
What's mom?
What other type of diabetes? Dr. Abhishek has got his hand raised. Please, Dr. Abhishek, tell us, solve the mystery.
Yes, ma'am. Actually, the fact is there is two major one that is already discussed, type
Yes,
1, type 2.
yes,
And other than that, the third one should came as gestational diabetes. You all know about that.
yes.
And you asked about the diabetes insipidus, that may be nephrogenic or neurogenic.
Yes.
And there are some other varieties. Actually, I
Yes.
don't remember that name, but I have the notes in front of me. I am just saying from there.
Okay.
That is called SAID, severe autoimmunodiabetes, SIDD, severe insulin deficient diabetes, SIRD, severe insulin resistant diabetes, MOD, mild obesity related diabetes, and MARD, mild age related diabetes, ma'am. Because I read these things long ago, ma'am. I don't remember this. That's why I'm just opening the notes.
I'm also looking for the answer that I'm looking for.
Okay, ma'am.
Okay, you can tell your answers, and then what is okay, cerebral nephrogenic diabetes?
Neurogenic diabetes mellitus, ma'am.
Neurogenic, yes.
Due to decreased production of ADH, ma'am. And another one is nephrogenic, that is decreased receptor sensitivity of the ADH, ma'am. ADH can't work at the kidney, ma'am. These two are the diabetes insipidus.
Yes. There is one, okay, central diabetes insipidus and nephrogenic diabetes insipidus. These
central
two
one
I
is
wanted you to tell me
ma'am.
the differences, yes.
Central one is that neurogenic.
Neurogenic, yes.
Yeah.
Very good, okay. That's where I was stuck. I wanted to hear this.
Yeah.
I'm sorry, yes, it can happen with anyone, you know, when they are stuck with something, they want to hear that answer.
I know, ma'am, this is your favorite question.
Yeah.
Like I have experienced 3 to 4 times this station, so I know that.